Good afternoon, everyone. Good afternoon, everyone. We want to welcome you to today's extension for community healthcare outcomes. Okay, and today we are discussing hepatitis B mono infection and what is the eligibility criteria for treatment. We want to acknowledge all our colleagues joining us from Kalingalinga, from St. Francis in Katete. We also want to thank our friends joining us from Kazungula Rural Health Center and from Gonda. We thank you all for creating time. So today we have the hepatitis B team from Accelerate. We will have a didactic presentation from Dr. Michael Vinikoor, and then we'll go into the case discussion, which will be presented by Dr. Ma Asobang. Here in the hub, aside me, Sombo Foloshi, there's Dr. Ma, there's Dr. Chisha, and we have Chatonda on IT. And most importantly, we have a special guest today, Dr. Christabel Mdiza. She's an obstetrician and gynecologist trainee, and she's part of the team that's being mentored in the management of hepatitis B. So her focus is actually in pregnant women. Dr. Christabel, you're welcome.
Thank you so much.
Okay, at this point, we'll allow Dr. Vinikoor to share his slide deck. And please take time to fill in the registration. Dr. Vinikoor, have you joined us?
Yes, I'm here. Can you hear me?
We can hear you very well. So I'll allow you to share your screen. And then I
think requested someone to share for me.
Okay, I think we'll do it.
Wasn't sure how stable my connection would be.
No problem.
Thank you.
I can't see it when I type it here. So just to mention that on the panel today, we have Dr. Lottie Hachambwa. Dr. Hachambwa, who's an ID specialist, heavily involved in the training here at UTH. Dr. Hachambwa, have you managed to join us? Then we have Dr. Bright Nsokolo, who's a gastroenterologist. And we have Dr. Mwemba and Professor Lloyd Mlenga supporting the panel for today. We hope at some point they can join us.
Okay, thank you, everyone. So my name is Mike Vinikoor. I'm an ID expert doctor and specializing in hepatitis from UT, coming to you from UTH HAP, but I work with several other institutions in Zambia, including CIDERS, and I work with University of Maryland on some projects. Next slide, please. So the learning objectives for this afternoon are to get some basic understanding of the natural history of hepatitis B virus infection, including natural clearance, to learn about non-invasive markers of liver disease, to identify the criteria to initiate tenofovir therapy in a person with Hbv mono infection, and to recognize the consequences of overtreatment and undertreatment. Next slide, please. So the first thing we wanted to impart on everyone on this call is that when you identify a person in Zambia, and there are many who have Hbv mono infection, the first thing that you should focus on is eligibility for treatment. So first of all, I just want to define mono infection because this might be a new terminology for some of you. So mono means one in I believe, Latin. And mono infection means just one infection. So when in the hepatitis world, we say Hbv mono infection, what we mean is the person has Hbv, but nothing else. So many of you know TB HIV co-infection, or you might know Hbv HIV co-infection. But today we're mostly going to talk about something new, which is Hbv mono infection. And so when you encounter someone who has HBV, but they're HIV negative, we don't have universal treatment. We don't have test and treat as a policy in Zambia yet. And you might be asking, why don't we just test and treat the way we're doing it very well in HIV? Well, there are a couple of reasons. First of all, treatment is lifelong in HBV for most of our patients. So once you start, we rarely ever stop. And then secondly, many people in the population who have Hbv mono infection, they have very mild infections. And we don't know, or we don't think there's a benefit from them taking medication. And so we feel that until we know there's a benefit, we shouldn't be giving everyone treatment for HBV. So at this point, we have eligibility. And for those of you who've been doing HIV treatment for so long, you remember the days when we used to have eligibility for HIV. So that's where we are for HBV. So the first thing you do when you find someone with Hbv mono infection is you have to check their eligibility criteria. So now at this point, let me talk about the virus life cycle because there are some differences from HIV. Thank you. So as you can see up in the top left corner, that's where the liver is. In case you weren't aware, the liver is just next to the stomach and its main job is digesting food, creating proteins in the body, helping to clot blood. So it's a very essential organ. Now, when the virus gets inside the body, it travels from the source of infection into the bloodstream, and eventually it goes into the liver because the liver has a lot of blood flow. So when the virus gets into the liver, you can see it meets the liver cell, and this is the cell that it's able to infect. So HBV only infects liver cells. And so the virus sticks to the liver cell, it goes inside, and like many viruses, it inserts its DNA into the cell nucleus. And then as the liver cell multiplies, it also multiplies within the nucleus. And so when that multiplication happens, more viruses are created. And so you get, on the bottom, you can see that you have various RNA transcripts are made into and then are reverse transcribed into a daughter virus. But the virus also makes a lot of surface antigen particles, HBsAg we call it. This is hepatitis B surface antigen. So even if the new viruses aren't being made, the surface antigen is still being made into the bloodstream. And so when you are out there in your facility and you order for a hepatitis B test, you're checking for the HBsAg in the blood or the serum or the plasma. So you can detect it in the blood of the patient. So when you find that surface antigen, you know that there is a liver cell in the liver that's been infected with the virus, and the virus is now replicating. Next slide, please. So this is a big teaching point in the field of hepatitis B that I wanted to mention to all of you, which is that in HB is that the damages are indirect. They're not direct from the virus. So once the HBV gets inside of your liver cell, the host immune system, which is represented there in yellow with red lines at the bottom, that's your host immune system, which is fighting off, trying to fight the virus. And it's that damage, the damage comes in when the immune system of the person is fighting the liver cell, trying to fight off the virus, which is on the inside. And so it's actually, the virus is very happy inside the cell. It doesn't cause the liver cell to die. It can just stay there for a long time without causing damages. It's really the immune system of the person that is causing the damage. This is very different from HIV, because in HIV, we know that if you have a high viral load, it leads to depletion of the immune system. Okay, someone might not be hearing me okay. Dr. Foloshi or Dr. Christabel, can you hear me okay?
Yes, we can hear you.
Okay, thank you for verifying. So in HIV, the virus infects to the CD4 cells and it eventually leads to the death of the CD4 cells. And that's what lowers our immune system. But in HBV, it's really the damages come in from the immune system itself trying to fight off the infection. Next slide, please. So after the initial infection, the patient can have two possible outcomes: an acute infection which resolves, or a chronic infection which can last for the whole life. And these are two different populations which we will talk about. First of all, young children. So many of you may know we provide vaccine to all children born in Zambia through the EPI program. And the reason we do that is because if young children are exposed to the virus, their immune system fails to fight off the virus 50 to 75% of the time. And so most children who are exposed early in life without any interventions or any prevention, they'll get viral hepatitis with hepatitis B, and it will be there in the body for many, many years. But in adults where the immune system is mature, about 90 to 95% of the time, the immune system does succeed in clearing out the virus after the initial exposure. So within 6 months of seeing the patient, if you have acute infection, only about 5 to 10% will continue to have the chronic form of the infection. So you can see here that, again, it's about the immune system. Children have weak immune systems, and they're less likely to clear up the virus naturally, whereas adults have strong immune systems compared to children, and they're able to clear the virus more than 90% of the time. Next slide, please. Now, what we concern ourselves the most with in Zambia is chronic hepatitis B, because thankfully our EPI program has reduced new cases a lot in the country. And so what we're more dealing with now are these chronic cases that are undiagnosed. So as you start doing more hepatitis work, you're going to find new cases, even within your own families, because it cuts all across society, and there are many people to be found. We estimate, according to the Zambia 2016, some of you might remember Zambia 2016, now we're doing Zambia 2021, but in Zambia 2016, we actually measured hepatitis B in the entire Zambia, and we estimate around 500,000 Zambians have the surface antigen in their blood. So they have active infection, and most of them are chronic infections. So this is what happens if the chronic infection sets in. The patient will pass through different stages of liver problems. Remember, the damage here is due to the immune system. So you start off with absent, what we call F0, and you can move progressively over towards significant, severe fibrosis, and finally cirrhosis. So this process takes many, many years. It can take 20 or 30 years potentially to go from 0 to the F4 stage. So it's really a silent killer, if you will. It's like high BP. You know, in high blood pressure, we don't get one day get high blood pressure and the next day we have a stroke. It usually is there for many years before it damages our body severely. And so it's the same thing in chronic hepatitis B. But what's interesting is that there are different people who progress and others don't. So if you look at the box on the right, we notice that people who move quicker from F0 to F4 are people with HIV, probably because of the immune system being deranged or inflammation. Anyone with immunocompromise also moves faster from normal liver to damaged liver. People with a raised ALT. So if you find someone with a raised ALT level, that's a sign that there's ongoing damage, which is pushing them from healthy to unhealthy liver. The high viral load is also associated with progression. And then there are some people where it runs in the family, where it seems like if hepatitis B gets into the family, it moves very quickly to complications. And then we've also seen there's some slight sex effect where it seems that women, especially during childbearing years, are more protected, and men progress more quickly over to cirrhosis. And then the people who don't progress as quickly are those who have normal ALT levels, which is typically a sign of no liver damage, low viral loads, and women. Next slide, please. And this is what we're trying to prevent. So these are the causes of death in Zambia from hepatitis B. Typically, these are people who have reached the most advanced liver disease called cirrhosis, or F4 liver disease. And at that stage, they are very high risk to go on to liver cancer. Secondly, they're at high risk for the liver to fail. And as I mentioned, the liver is so vital to the body for clotting blood, for digesting your food. Those people will present with ascites, a swollen belly, a swollen stomach with water in their stomach, encephalopathy, which is the medical term for confusion, altered mental status, unusual behaviors, which has to do with the digestion of the food, and then bleeding. So people who have easy bruising or bleeding. And finally, these patients also have high risk of other infections because the liver does play a role in the immune system. So if a patient reaches cirrhosis, and about 5 to 10% of the people with hepatitis B reach this stage in Zambia, they're at very high risk to pass away prematurely from these complications. Next slide, please. So this is a summary, and then I'm going to go in more detail as how we're trying to develop a public health approach for HBV management in Zambia. And this is based upon the Ministry of Health 2019 guidelines. So the first and most important step, and I know all of you will have no problem with this one, which is verifying the HIV status, because many of the people who have hepatitis B also have HIV. So they're not mono-infected, but they're co-infected. And for those patients, you know very well, you will link them immediately to ART, where they'll be given appropriate ARVs that treat for HIV and hepatitis. But if the patient is mono-infected, you go on to step 2. And in step 2, we require some basic lab tests to check eligibility. And you have to examine the patient very carefully to look for signs of chronic liver disease. In step 3, you have to assess whether it's an acute or a chronic infection. In step 4, if it's chronic, you'll use your lab results and your exam to determine eligibility for treatment. And then if necessary, you'll reassess the labs in step 5, and you'll follow up the patient to do continuous reassessment for eligibility. And ultimately, the ones who are going to be started on treatment will have cirrhosis or persistently elevated ALT. So now let me go into the details. So we're trying to develop this 5-step approach. But before we do that, we're going to go to our first poll question to see if you've picked up some basic information about HBV. So let me read the question and the responses, and then Dr. Cristobal will bring up the poll. So in Zambia, there are approximately 500,000 people living with chronic hepatitis B infection. Which groups among these are at increased risk to develop a complication like cirrhosis or cancer of the liver? So out of all these people with hepatitis, which of the following is at higher risk to progress onto cirrhosis or cancer of the liver? Is it A, healthcare workers, B, pregnant women, C, people co-infected with HIV, or D, people with detectable but low levels of the HBV viral load? Okay.
Thank you so much,
some
Dr.
responses.
Vinikoor. Yes, thank you so much, Dr. Vinikoor. I'll allow Cristobal to read through it again as people are voting.
Okay, so in Zambia, there are 500,000 people with chronic hepatitis B infection. Which groups living with chronic hepatitis are at an increased risk of developing a complication like liver cirrhosis? So there are the different variants. A, healthcare workers. B, pregnant women. C, people co-infected with HIV. And D, people with detectable but low levels of hepatitis B viral load.
Okay, so we have only 50% of us have voted. We'll give that a few minutes to allow everybody to vote. Please go ahead and vote. Remember that the voting is anonymous. I'll allow Cristobal to read that again.
Okay, so we have said that there are 500,000 people with chronic hepatitis B infection. So which of the groups living with chronic hepatitis have increased risk of developing complications like chronic liver cirrhosis? So we've got A, healthcare workers, B, pregnant women, C, people co-infected with HIV, and D, people living with detectable but low levels of hepatitis viral load.
Thank you so much, Dr. Mbiza. So I will share the voting pattern in a minute. Okay. So this is how we voted. Most of us felt that people who are co-infected with HIV and have hepatitis B are at increased risk of cirrhosis or having active liver cancer. We have a few votes in the other categories. I'm sure Dr. Vinikoor will elaborate.
Thank you. Great job, everyone, and thank you for voting. I think most of you picked up on the fact that because HIV impairs your immune system and it causes inflammation in the body, that we, not surprisingly, have seen that having HBV with HIV as a co-infection will lead to more complications of HBV. And so this is really a priority population for HBV treatment. And we're very grateful for all of you who focus on HIV treatment because you're benefiting people with HBV as well. And we had a few votes for option A, healthcare workers. So healthcare workers in themselves are not at higher risk to go on to get the complications, but that was a slight trick of the question because healthcare workers are a key population to get the infection to begin with. But once they have it, they have a normal, typical risk of progression. So if we were talking about prevention, yes, healthcare workers are really important to prevent hepatitis B. And finally, a few of you picked option D, detectable but low levels of the viral load. So those are actually the people with inactive hepatitis where we don't usually give treatment because it's very inactive in the body. Thank you very much. I'll move on to my next slide. So as I mentioned, the first step is confirming the person does not have HIV. So now you've confirmed and you're now looking at a person, talking to them, counseling them, and they have Hbv mono infection. And of course, they want treatment. You have to counsel them that first we do eligibility before treatment. And the eligibility requires some basic laboratory tests. So very basic things that pretty much everyone on this call has at their facility. So we're talking about the most important is the ALT test. So the first and most important is ALT. This is the thing what we use in hepatitis to check for liver damage, okay? Another thing we use is the full blood count. Another thing, which is another test that you have at your facility. We look at the platelets. So many of you who are doctors will remember from medical school that if the liver becomes damaged, like the spleen, the platelets can start dropping. So if you see low platelets, this can be a sign of liver damage, just like a raised ALT is. And finally, we recommend creatinine because typically your treatment is going to be tenofovir. And therefore, if the patient has chronic kidney disease, you would want to be very careful before prescribing tenofovir. Next slide, please. So this is another big teaching point, I think, for most people on this call. Most of the time, we see raised ALTs in our practice. And a lot of times we kind of ignore them because they're just mildly elevated. But when you have a person in front of you with HBV, you have to pay extra attention to the ALT. Because according to data from around the world, we've adopted these thresholds for what is considered liver damage in a person with HBV. So you can see that if a woman has an ALT even above 20, so going from 20 up, that could be sign of a liver damage, which puts them in that category of high risk to progress on to cirrhosis or cancer. And for men, it's from 31 and above, and similarly for children, 31 and above. So essentially, when you get your ALT results back, this is what you should be looking for. So you can think of the ALT as your CD4 count, as we used to in the old days of HIV. So if the ALT is below these thresholds, a lot of times we won't be starting them on treatment. But when you see the ALT raised above these thresholds, this is a sign they might need to go on treatment. Next slide, please. So going back to our stepwise approach. So you'll check your HIV status. You'll do your basic lab tests, which should be available in any health center or first, second, third level facility. You'll have the patient come back when the results are out. Now, the next thing you need to do is to determine, is this acute or chronic HBV? Next slide, please. Okay, so typically in a patient who comes in with hepatitis, you're going to do these blood tests and then you're going to reassess. And so let's talk about acute versus chronic HBV. As I said, when you're just exposed to the virus, people can have an acute hepatitis B. And this is typically a person who presents with a rapid onset of jaundice in the previous couple weeks. So we're not talking about jaundice for 6 months or someone who says, I get yellow eyes off and on since I was a child. We're talking about someone who is in perfectly good health and within some days or even 2 weeks, someone noticed their eyes turned yellow, they're starting to have some fever, they feel unwell, they have vague symptoms like fatigue, maybe abdominal pain, and they're referred over to the health center. And someone, usually a clinician like you all, has done a hepatitis B test and it's positive. So in these acute hepatitis B episodes, the ALT is very, very raised. These are some of the highest ALTs you'll ever see working in the hospital. So the ALT might be more than 500, even more than 1,000. So typically when the lab gives you the results, you notice how serious it is. That's the picture of acute hepatitis B. So if the patient in front of you tells you that story and has the high ALT, then you've got an acute hepatitis. What does chronic hepatitis look like? Well, it's typically silent. So a lot of the people we see at UTH with chronic hepatitis B, they didn't know they had the disease until either they went for testing as required because they became a blood donor, they got pregnant, they went for medicals, or because they suddenly developed cirrhosis and started getting sick over several months. So basically their liver started to malfunction. And when we do their initial blood test, we never see high ALTs like 500 or 1,000. Typically, we can even see a normal ALT or the ALT is only raised to 200, 300. So it's very important for you to determine which group the patient is in. And why is that? Well, if you have a case of acute hepatitis B in front of you, although the patient will be very worried, and you will as well, because you see someone with an ALT of 1,000 and a high and jaundice, and maybe they don't feel well. Typically, that's a good sign that they're going to clear the infection. So you can tell them that most likely this is going to get better on its own and resolve. But unfortunately, when you see someone with chronic HBV, it's most likely a lifelong infection. Can you go to the next slide, please? So after step 3, if the patient has acute hepatitis B, we typically just follow up clinically and we recheck the HBV status in the next 6 months. And sometimes based upon the level of the ALT, we see them back for reviews after 1 or 2 weeks. And there are some rare cases where you need to refer them because they're developing complications such as liver failure, which can present with the bleeding or confusion, etc. But I would say that 95% of the acute hepatitis B cases you'll see, the patient will look unwell and have yellow eyes, but they'll actually resolve their hepatitis B spontaneously. So there's no indication to put them on treatment. So if you have chronic hepatitis B, you go on to step 4, which is really the central mission of today's talk, is to tell you about eligibility. Next slide, please. So these are the indications to start prescribing treatment for someone with Hbv mono infection. So number 1, cirrhosis. So if you're suspecting that there is chronic liver damage for any reason whatsoever, if you have any sign, maybe it's an ultrasound showing some ascites, maybe it's when you examine them, maybe it's their body type, you see the typical patient with chronic liver disease. If you have any reason to think they have cirrhosis, you need to start treatment. Secondly is what's called persistently raised ALT. So as many of you know, an ALT test, which as I mentioned, is kind of like our CD4, unfortunately, it's not very specific for hepatitis B. Many things can raise the ALT. So if you see a raised ALT, you should also screen the person for other conditions like alcohol, other medications that they might be taking, maybe some traditional medications, and ask them. And then if you do find one of these things, maybe you can recheck the ALT after they stop taking or after they've reduced their alcohol use. So typically, when I say persistently raised ALT, we like to see 2 ALTs consecutively that are both raised. So typically, Dr. Sinkala and others, if we see a raised ALT, we'll have the person repeat that after several months, and then they'll bring back the results. And if it continues to be raised, despite looking for other things, we will conclude that's the hepatitis and they meet treatment criteria. And then the third criteria is really acute hepatitis B with indication of liver failure. So if you have a concern that this person not only has acute hepatitis, but there's a chance their liver could be failing, then it's better to go ahead and start antiviral therapy. And what we like to say is that when in doubt, it's okay to treat. And why do we say this? Because I know that I remember when we were doing eligibility for HIV, there was a lot of, people were uncertain when the CD4 was right around the threshold. But in hepatitis B, we can say with confidence that if you feel strongly as a clinician to go ahead and start treating, you should, because the medication is low cost, it's very safe to people. We have so much experience in Zambia giving tenofovir type treatments. And we know that sometimes retaining people in treatment is very hard when they're not given a prescription. And so we don't want you to miss the opportunity to put someone on treatment who can benefit from it. So if you're really in doubt or you're on the fence about the criteria, we do recommend you go ahead and start them on treatment. Next slide, please. Okay, poll question number 2. I'm going to hand it back to Dr. Christabel.
Okay, a 22-year-old female university student who was previously in good health presents with yellow eyes, fever for 5 days. He had unprotected sex 1 month ago. On examination, she has jaundice, but does not have signs of cirrhosis, bleeding, or confusion. Her lab background is the hepatitis surface antigen is positive, HIV negative, and the LLT is raised to 1,120. So, which of these suggests acute hepatitis B mono infection? A, she's a university student. B, ALT is very, very high. C, jaundice. D, recent high-risk sex.
Okay, please go ahead and pick which of these you feel is the correct answer. HIV negative students had sex a month ago, comes with yellow eyes and fever. Has no signs of acute liver failure. She's not confused or cirrhotic or bleeding. But her labs come back and the LT is 1,120 international units per liter. But her hepatitis B surface antigen is positive and she's HIV negative. Which of these suggests an acute hepatitis B virus mono infection? We have 50% voting. We'll give that a few more seconds before we close.
Okay, those that are joining, welcome. We're taking it to the polls. We're on question 2. A 22-year-old female university student who was in previously good health presents with yellow eyes and fever for 5 days. She had unprotected sex 1 month ago. On examination, she has jaundice, but does not have signs of cirrhosis, bleeding, or confusion. Her labs come back. The hepatitis surface antigen is positive. She is HIV negative. The LLT is raised to 1,120 international units per liter. Which of these suggests acute hepatitis B Mono Infection? A, she is a university student. B, ALT is very, very high. C, Jaundice. D, recent high-risk sex.
Thank you so much, Dr. Isabel. We are sharing the results, Dr. Vinikoor. Please go ahead and elaborate. A special welcome to the mentors that are joining us from Mulungushi. There are more than 74 people that have joined on one connection. So we actually have way more than 408 participants. So thank you so much, mentors, for joining us. Dr. Vinikoor.
Yes, welcome, mentors. Yes, so the most commonly selected response was B, ALT is very, very high. That is the correct answer. And so what I wanted to teach you all is that in acute hepatitis B, we will see very, very raised ALT levels, even surpassing 1,000. But chronic hepatitis B, which is more commonly in Zambia, you may see only mildly raised ALT. So the difference here is that acute hepatitis B is actually a sign of a strong immune system, and most likely that person will resolve their hepatitis naturally, which is a very good outcome for them. Whereas chronic goes on to linger for the rest of the life, potentially. And so 19% of people selected jaundice, which is not necessarily the wrong, but it's not the not very specific for acute Hbv mono infection. Jaundice can be a sign of chronic or acute hepatitis B. It just is when your bilirubin is raised due to liver injury. And so that's not, it can be definitely seen in acute hepatitis, but the characteristic finding is the raised ALT. And then finally, several people chose high-risk sex. So high-risk sex in itself doesn't have, isn't very specific for acute hepatitis B. You can get hepatitis B infection from several different ways, including from sex, from exposure to someone at your household, from exposure to blood or needles, for example, if you're a healthcare worker, and there are different ways of getting it. So sex is just one of many ways to get to be exposed to the virus. Okay, next slide, please. So now I hope you've learned something about when you should start treatment in a person with hepatitis B mono infection. So, now you've decided to go ahead and start. What do we prescribe? And I think this is quite easy for many of you because you're comfortable with these medications. But I just want to point out that for adults and adolescents who meet the weight and age requirements for the type of tenofovir, we give the fixed dose combination of tenofovir DF plus lamivudine, or if it's more readily available in your facility, you can also give TAF with lamivudine if that's available to you. But the hepatitis B virus doesn't require the cocktail of drugs like we give in HIV. So even if you happen to find tenofovir DF alone, you can also give that one. As long as tenofovir is there, you're covered. The reason our preferred is the tenofovir DF plus lamivudine is just a programmatic consideration because that's the combination that's very commonly found in the pharmacy in Zambia. And so we want to give people something that is very commonly found. And so although tenofovir alone would be okay, it's commonly found co-formulated with lamivudine. And then if you have a child, which thankfully it's a very rare thing these days when you have a child with hepatitis B and they meet the criteria for treatment. But if you do see these children, which is possible, and they don't meet the criteria to go on to tenofovir because of their age is too low or because their weight is too low, we would give them lamivudine alone, which is safe in children. So these are the medications you would prescribe. And so just take note of the fact that the typical ARVs you give, such as TLD or TLE, those have 3 drugs in them. And for hepatitis, we really need only 1 or 2 drugs. We can get away with 1 drug or 2 drugs is more common. And so the important thing is to treat as many as we can with the tenofovir. And if it's a child who's too young, we'll have them on lamivudine until they reach the age where they can go on to tenofovir. Next slide, please. Or maybe I'm done. Okay, yeah, I think we're just wrapping up. Yep. This is poll question number 3. Back to you, Dr. Foloshi, Dr. Christabel.
Which of these hepatitis B mono-infected individuals should start antiretroviral therapy due to persistent elevated ALT? A, male adults, ALT levels of 32, then 18, then 45. B, female adults, ALT of 15, 14, then 19. C, child with ALT level of 28, then 25. D, female adults, ALT of 15, then 23, and then 27.
Okay.
So we can take it to the polls, those that have heard, those that are joining, welcome. We are polling question number 3. Which of these hepatitis B mono-infected individuals should start antiviral therapy due to persistently elevated ALT? A, male adult, ALT levels of 32, then 18, then 45. B, female adult, ALT levels of 15, 14, then 19. C, child with ALT levels of 28, and then 25. D, female adult, ALT of 15, then 23, then 27.
Okay, I will let this one run for a few more seconds because we acknowledge that it has a bit more technicality to it.
Yes, for this one, the important word is persistently. For those of you who have picked up that small detail I mentioned, will get this one.
Okay, so we allow Dr. Christabel to read that again. Remember that these are being done in a period of 3 months in between.
Okay, so which of these hepatitis B mono-infected individuals should start antiviral therapy due to persistent elevated ALT? A, male adult, ALT levels of 32, then 18, then 45. B, female adult, ALT levels of 15, then 14, then 19. C, child with ALT levels of 28, then 25. D, a female adult with ALT of 15, then 23, then 27.
Okay, we are going to end this call and allow Dr. Vinikoor to elaborate.
Thank you, doctors. So in this was a very challenging question because it requires 2 things. Number one, it requires you to remember the threshold for elevated ALT, which is 30 and above in men and children, and 20 and above in women. And then the second thing is it requires you to understand the concept of persistently elevated. So persistently elevated, we define it as 2 consecutively raised ALTs over a period of months. So as I mentioned, sometimes a person with hepatitis B comes with a raised ALT, but that in itself doesn't qualify them for treatment. What we recommend then is for them to repeat after a few months, and if it continues to be raised, then we know they have the high risk phenotype and they should go on to treatment. So if you look at these, in option A, you have a male, so we're looking for above 30. And sure enough, his ALT was 30, but then it rose again. So this is a fluctuating picture. It wouldn't be persistent. In option B, we have a female, so we're thinking about 20 and above. And this female had several ALTs and they're all normal. So in option B, this woman is probably with very inactive hepatitis and did not need treatment. And then in C, we have a child. So we're looking at 30s and above. And again, both of them are under 30. So this child wouldn't qualify. And D, we're looking at a female again. So we're looking for 20s and above. And although the first ALT is 15, then comes in at 23 and 27. So when she reaches this ALT of 27, now you have 2 in a row that are raised. And so this is signifying that the liver is getting chronic damage and you should initiate treatment. So that's why we put a lot of emphasis on eligibility for treatment, because this is a new infection for many of you to be managing, and you know, it's going to require a lot of training, and you're going to be hearing this over and over. So this concept of persistently elevated ALT, hopefully now you've picked up on the fact that you first need to identify a raised ALT, and then you need to recognize that persistent means that it's continued to be raised over 2 measurements. Okay, I think I'll hand it back to our facilitators. Thank you.
Thank you so much, Dr. Vinikoor. I would like to acknowledge that we've actually been joined by Dr. Sinkala on the line, so he will join our panel of experts. So just as we prepare to transition to our case, I will allow some input from our network. There's quite a lot of questions. I'll allow Dr. Mbiza to pick some, but I will prioritize people who have their hands up. I want to welcome Dr. Cassidy. Yeah, welcome, Dr. Cassidy, part of the ID team here at UTH. Jackson, please go ahead with your question. I can't hear. I know, Jackson, you are talking, but we can't actually hear you. He's actually unmuted. Yeah. And I know Dr. Sinkala is talking. Jackson, yes, go ahead. Unfortunately, if you have not, yes,
able to get me now?
Yes.
Yes, I'm saying I wanted to find out. Nowadays, we're having a lot of clients coming coming with hepatitis after being maybe 3 years on the TLD based regimen, of which one of the TLE is one of the components that we use to treat hepatitis, like which is having lamivudine and tenofovir. Another thing is we're having one client. I came across one client who had been on PrEP and is tenofovir lamivudine for over a year, and he had been having hepatitis B positive consistently. What could be the problem?
Jackson, that's a very good. Dr. Minani, can you please stop sharing your screen? Let's block that screen. Dr. Minani, please stop sharing your screen. Thank you. Jackson, that's $1 million question. I had to write a test last week and that question came up. That's a very, very good question. I will allow 3 more questions and then allow our panel to answer. Unfortunately, if you've raised your hand and you have not named your device, we are unable to take your question because we can't pronounce what that is. So we will take some questions from the chat. Please rename your device to your name. I'll allow, wow, this is a lot of questions. So I actually just have to come. There's a question.
Okay. Gabriel Weston. Okay. HIV hepatitis B client on AZT3TC, Detegrava, and TDF. We don't have FDC that allows us to give this above regime. How easy is it to administer this regime based on the FDCs we have in Zambia?
Okay, that's another very good question. Very, very practical. Typically comes in when we are changing people to second line. and then they have hepatitis B. So what do you do about the hepatitis B? So that's the genesis of this question. Great question. This is a lot of questions. Okay. So there's Gladys. I like Gladys's question already. You can just read it. Yes.
Okay, so we have a case of food handler in Isoka that has been tested positive for hepatitis B for over 2 years and also happens to be an ART client. So my question is, the hepatitis disease isn't just clearing, or is it that the clearing of it, or is it that the medication from the ART is affecting her results? If the results are being affected by the ART medication, how long will this false positive go on? Is it for a lifetime, or can we help her?
Nice question, Gladys. The only thing is that you haven't told us the regimen. It would be nice if you actually type what regimen you're talking about, because we are curious about that. Dr. Vinikoor, do you want to take one and two? Then I'll let Dr. Sinkala take 3, or you can take all of them. It's up to you.
No, it's fine. I think they go along with the similar theme, which is that the reason I showed you the viral life cycle is I want you to see that the virus actually goes inside the liver and it creates a reservoir. So even when you take ARVs, the viral load reduces and the liver damage reduce, but that reservoir is still there in the liver. So this is why once we start people on treatment, we don't stop, because it can reactivate from the liver reservoir. And so for the patient who was on TLD for many years, I think that was Mr. forget whose question that was. The person will continue to test positive for hepatitis B. It's not a surprise because the virus is still there inside the liver, but you've done well to put them on ARVs that include tenofovir. And similar to the case with PrEP. So in a PrEP patient, if you decide to stop the PrEP in that patient, you would then need to go back to our 5-step approach to determine if they need to continue on treatment for their hepatitis B alone. And with the food handler, again, it's the same thing. This is a lifelong infection. And the appropriate thing is to keep the person on the ARVs that include tenofovir. And the hepatitis B does not spread through unsafe food handling, by the way. It can only spread through intimate contact or contact with blood or with contaminated needles. And then I think I'll just pick up the last case here, which is second line. So thank you very much for mentioning second line, because those of us who do hepatitis, we love TLD because it has T, which is tenofovir, in there. So it caters to our patients. But you don't have standalone tenofovir, so you have to give Truvada. So you would end up giving AZT3TC, Truvada, and Alluvia potentially, or DTG in this case. And so what happens there, and I know what's concerning Gabriel, is that the patient is getting 2 doses of lamivudine. And that double dose of lamivudine is felt to be safe by the experts. And we've discussed that within the country and with international experts. Lamivudine is one of our safest ARVs. And so in those patients, giving them the double dose would have very few, if any, side effects, and it would benefit them by controlling the HBV. Well, let me stop there. Thank you.
Thank you so much, Dr. Vinikoor. I have seen Sydney. Sydney, please go ahead with your question. In the interest of time, we'll have to allow Dr. Ma to come through with her case. Sydney, please ask your question. Dr. Mulumba will put your question aside for now. Sydney, please go ahead with your question, and we want. Sydney, sorry, we lost internet. Are you able to ask your question?
Yeah, I'm here. I just wanted to ask if someone has what do I say? The creatinine clearance of 30 and below, which regimen would be suitable for this client, since we cannot give TDF.
Okay, Dr. Sinkala, do you want to take that question? Somebody with a creatinine clearance less than 30, I believe. What regimen can we give somebody who has hepatitis B? Dr. Sinkala or Dr. Cassidy?
Right, thank you, Dr. Foloshi, for that question. Yeah, so TDF may not go well with a patient who has creatinine clearance of less than 30. So you may want one to consider using TAF, okay, tenofovir. Alternatively, you can use what we call entecavir. Entecavir is renal friendly, has no renal issues. But the only challenge we have is that entecavir is not readily available in Zambia. People have to like source it, buy it from somewhere. But in that case, you may want to consider TAF, tenofovir as an option.
Thank you. I think that is a good one. It's got good effectiveness. I'm not sure if Sydney said creatinine clearance less than 30. Or was it 30? But then TAF is good if your creatinine clearance is above 30. Anything more than that, you may have to use lamivudine monotherapy, knowing that it has no biotic resistance, or of course, entecavir if it's available. So thank you very much, Dr. Kongolo. I'll allow you to ask a question. It's a bit of a tough one for the session we have today, but please go ahead and ask. Dr. Sinkala, I see you are still unmuted. I'll allow Dr. Vinikoor a breather. Dr. Kongolo, please go ahead with your question. Dr. Kongolo. So Dr. Kongolo was asking, what is the role, Dr. Sinkala, of hepatitis B and I think viral load?
Yeah, hepatitis, viral load, and hepatitis E, immunoglobulin M, and immunoglobulin G.
Dr. Sinkala, I'm sorry. I think he typed it out. I hope he still don't know about hepatitis B. Okay, Dr. Kongolo.
What is the role of the hepatitis B viral load? And he asked, in addition, hepatitis E antigen, immunoglobulin M, and immunoglobulin G.
Okay, so I think the viral load is trying to ask the importance of hepatitis B DNA, which is a viral load. So it's one of the characteristics we use to see if we could start a patient on tenofovir. So if the patient has a viral load of above 2,000, okay, international units, and then the liver function tests are high, you would want to start medication in that particular patient. I'm sure the other question you wanted to ask is the role of the E antigen, I think. So the E antigen is important because it shows that one has, it shows infectivity. It shows that one is more infectious. The virus is replicating, okay? And then the IgM is a marker that you can use actually to check if you are in doubt whether the patient has acute Hep B or chronic Hep B. So the IgM antibodies are actually elevated in acute Hep B. Like Dr. Vinikoor said, in acute Hep B, remember that ALT is a very good marker. If it's very elevated, above 500, then you might think of acute Hep B. But if you have IgM antibodies, then that signifies acute hepatitis B infection.
Thank you.
I hope I got.
Yes. Very helpful. But I will tell you one thing. This is just one of the lectures in this series. So we'll come back more and talk more about what Dr. Sinkala just described. I've seen Dr. Vinikoor reminded me of things that I missed. You can actually give tenofovir every 24 hours, every 48 hours, every 72 hours, depending on the creatinine clearance. You don't have to give it every day. So that's also an option. At this point, we'll allow Dr. Ma to introduce herself and we'll share her screen. Please go ahead, Dr. Ma.
Thank you so much, Dr. Rose. So my name is Dr. Ma Zambia. I'm a hepatitis B.
Please let's mute our microphone. Please go ahead.
I'll be myself just in case I'm going to get that. So my name is Dr. Ma Zambia. I'm an hepatitis B coordinator at the Center for Infectious Diseases, or as fighters. And I'll